Continent fecal diversion procedures. Surgery can be done on both the intestinal or urinary system to divert the fecal or urinary stream and result in a continent procedure, meaning the individual has to some extent control over the bowel or urinary function. We will first address continent bowel surgeries. The continent ileostomy is also called the Koch pouch or K-pouch, named for Dr. Nils Koch, who developed this procedure in 1969. This is an option for individuals who prefer not to wear an external pouching system and are unable to have a workable pelvic pouch. A continent internal reservoir is created, and individuals use a catheter to enter into a flush abdominal stoma and empty out the contents of the internal reservoir. This procedure is used with patients with diagnoses including ulcerative colitis, familial adenomatous polyposis, cancer of the colon and rectum. Those who've had a conventional ileostomy or pelvic pouch malfunction and also have a preference for the continent ileostomy due to psychological, social, or sexual reasons. This procedure is not seen as often as other types of stomas and is generally performed as a conversion procedure for those with a malfunction, not as a primary procedure. Its use is limited to medical centers with surgeons experienced in pouch surgery. Contraindications for formation of continent ileostomy would include Crohn's disease, obesity, an acute severe colitis, and those who are physically incapable, mentally unreliable, had a previous or desmoid tumor. In some instances, if the patient is disease-free after 5 years, a pouch could be considered for the person with Crohn's disease, but this is a highly selective group, and there is still a high risk of recurrent Crohn's disease in the pouch, with subsequent pouch loss, meaning over 45 centimeters of small intestine will then be gone. There are 2 ways to create the continence mechanism for an internal catheterizable stoma: intussuscepted or living collar. It is also known as a Barnett pouch. So why would a patient want to convert from a conventional ileostomy? Well, if you take a look at the photo on this slide, this person has a permanent ileostomy located in a very poor site, immediately above the pubic crease and near the groin, which of course makes pouching a complete nightmare. Multiple scars on the abdominal area obliterated other potential sites that may have been used for a conventional ileostomy. The patient had enough and needed another option. Additional reasons for continent ileostomy include severe allergy to ostomy equipment, intractable difficulties in pouching, and patient preference for a continent stoma. In this procedure, an internal reservoir is created out of segments of ileum. A piece of small bowel is implanted into the pouch and on another piece of ileum used to exit the pouch and wrap the exit conduit. This segment of ileum fills with effluent and closed off the exit conduit of the pouch, providing this pouch with continence. The method of continent ileostomy construction used at Cleveland Clinic will be described in the next slide. So let's work through step by step how this occurs. In step number 1, 19 to 20 centimeters of the terminal ileum is sectioned out of the small bowel, and the 3 12 to 15 centimeter length segments are measured and marked with stay sutures. In 2, creation of an enterotomy on adjacent limbs of the pouch, and 3, approximation of the mucosa on the back wall of the pouch is created. Number 4, we have intussusception of the nipple valve to create the continence mechanism. Number 5, the anterior wall of the pouch is closed and the pouch is tested for integrity and continence. Number 6, the exit conduit is brought through the anterior abdominal wall, the stoma is created, and a drainage catheter is in place with the abdominal wall then closed. To recap, a total proctocolectomy has been done, a reservoir with a nipple valve is created, and a continent stoma is formed. The individual would then wear a bandage over the stoma. These stomas do not require pouching. Intubation occurs about 4 to 6 times a day. Complications for continent ileostomy surgery are listed on this slide. The most common complication seen is slippage of the nipple valve. This means the valve has moved out of position. As a result, the individual is either continent of effluent or gas and stool, depending on the degree that the valve has slipped. Or more commonly, the person just is unable to intubate it. When this occurs, it is a medical emergency because the person cannot drain the pouch contents. If a change in position, such as lying down, sitting on the commode, or standing up, use of a stiffer catheter, the usual catheter can be placed into a plastic bag, then put into a freezer for 20 minutes, or relaxation of the abdominal muscles through a warm bath or shower, drinking a glass of wine, or taking deep breaths, do not help. The individual needs to seek medical assistance urgently. Once the catheter is inserted into the internal reservoir, it needs to remain in place and should not be removed. An appointment with the surgeon who performed the surgery needs to be made. An evaluation of the pouch and valve mechanism is usually done using a flexible scope. Sometimes splinting the valve with a catheter is enough to correct the situation, but in the majority of situations, the individual is going to require reoperation to correct the problem. Pouchitis is another common problem that can be encountered by those with any internal fecal pouch. The symptoms typically mimic those that were present when the person had ulcerative colitis and include increased frequency of pouch intubation, blood in the stool, malodorous drainage, and discomfort in the area of the pouch. Although the etiology of pouchitis is unknown, the most studies suggest that there is an abnormal immune response to the pouch microflora, which lead to both acute and chronic inflammation. Approaches to treatment of pouchitis have involved the manipulation of both the pouch microflora and mucosal immune system. For patients with chronic pouchitis, long-term, low-dose antibiotics or antibiotics followed by probiotics should be considered. In patients who continue to have problems, oral budesonide may control the symptoms. In some patients who continue to have refractory disease, immunosuppression or immunomodulation with 6-MP, azathioprine, or infliximab can be considered. Rarely, the person may require resection of the internal pouch with creation of end ileostomy. Patients who are candidates for the pelvic pouch procedure include those with ulcerative colitis, familial adenomatous polyposis, cancer of the colon and rectum. It can be an option for those with indeterminate colitis, depending upon other symptoms the individual may exhibit, such as perianal disease. The colon and rectum are removed, and the internal reservoir is fashioned from small intestine and anastomosed to the anal canal, preserving sphincter function. Two of those most common types of ileopouch construction are the J pouch and the S pouch. Regardless of surgical construction, if the internal pouch is constructed with reasonable volume, a good blood supply, and minimal tension on the anastomotic site, there should be good functional results. The most common type of ileopouch reservoir is the J pouch. It is a two-limbed pouch with each limb of the pouch being about 15 centimeters or 6 inches in length. The distal end of the ileum is stapled closed, and then the small bowel is folded over on itself to resemble the letter J. A special surgical instrument cuts and staples the two limbs in such a way as to make an internal reservoir. The base of the J is opened and attached to the top of the anal canal. This type of ileopouch construction is technically easier to perform and provides better continence, particularly during nighttime. The S pouch uses 3 limbs of ileum for construction, with each limb being 5 to 6 inches in length. This type of pouch would be hand sewn. In this type of construction, a mucosectomy, which is stripping of all visible mucosal tissue from the anal transition zone, would occur. With the S construction, a single length of ileum is used to attach to the anal transition zone, resulting in a narrow diameter of ileum at this point. This helps to make the pouch reach to the top of the anal canal in those people with a narrow pelvis, such as in some men. This construction type is also a good choice if the J pouch is attempted, but the surgeon is unable to reach the top of the anal canal. The single limb gives enough length to reach where the J-style pouch cannot. For those with an S pouch, generally some have some nighttime fecal incontinence for up to 9 months after surgery, as the anal sphincter mechanism has been stretched more and for a longer period during the surgical procedure. There is also a diverting loop ileostomy created with this type of construction as well. To recap on the stages, the IPA surgery can be done in 1, 2, or 3 stages. Much depends on the health of the person and the urgency for need of surgery. Most commonly, you'll see a 2 or 3 stage procedure. A 3-stage IPAA is done when a patient is critically ill. They may be on high doses of steroids or have long-term use of steroids or other immunosuppressive therapy. Additionally, the person may have fulminant colitis and be septic, with symptoms of increased heart rate, decreased blood pressure, increased white blood cells, and an extremely dilated colon. This person needs urgent surgery with the goal of removing the colon to decrease the disease burden. It is amazing how much better these individuals feel as soon as the diseased colon has been removed. In this first stage in stage 1 of the 3-stage IPAA, the entire colon is removed. This is known as total abdominal colectomy or subtotal colectomy. The rectum remains in situ, so the person will still pass mucus and perhaps a little bloody discharge from the rectum. How the rectal stump is treated depends on the quality of the tissue. If they are in good shape and the sutures take well, the top of the rectum is staple closed and sutured to the subcuticular layer at the midline of the abdominal incision. If the tissue is more like tissue paper and does not take sutures well, then the top of the rectal stump is brought out through the lower midline incision as a mucus fistula. This first stage allows the person to get off of medications and recover nutritionally. The second stage of the procedure is done anywhere from 3 months to 1 year following this initial stage of surgery. The individual may decide not to have further surgery, in which case they would need to have routine surveillance of the rectum with biopsies for life. They may eventually have to make a decision on removal of the rectum. In most cases, the colitis in the rectal stump goes into remission. However, it can flare up with symptoms of bleeding, fatigue, and increased mucus production. This is managed with small steroidal enemas, and if this is unsuccessful, then an oral steroid can be given. In the second surgery of the 3-stage IPAA procedure, a proctectomy is performed, leaving the anal canal in place. An ileal pouch is then created and joined to the top of the anal canal at the anal transition zone. A loop ileostomy is made upstream of the internal pouch in order to divert the fecal stream and assist in healing. This ileostomy is left in place for usually about 3 months. It is important to remind patients that they may have mucus coming from the internal pouch out through the anus. They may not have continence of mucus, particularly at night, so use of a pad when sleeping is recommended. The loop ileostomy is a new stoma that is brought through the old ostomy site. This stoma tends to function closer to skin level. It may require modification of the pouching system used compared to what was used with the prior stoma. Dehydration is common. Management of this will be discussed in the management section of continent fecal diversions. The final surgery of the three-stage IPAA procedure is closure of the loop ileostomy. It is recommended that a minimum of 3 months pass prior to stoma closure, but earlier closure can be done if the IPAA was created with a laparoscopic approach, secondary to having less adhesions, dehydration is unable to adequately be controlled, or if there are insurmountable pouching issues. Prior to closure, anal manometry testing is done to check on the strength of the anal sphincter muscles. Additionally, a digital rectal exam is done to assess the integrity of the anastomosis, and a water-soluble radiopaque enema is completed to check for defects in the pouch or the anastomosis. Stoma closure is done through the stoma site alone. It does not require a formal laparotomy. The fascia is closed, leaving the tissues to heal by secondary intention. One should use the principles of moist wound healing when working with this site, and it can take about 4 to 6 weeks for this to heal completely. The first stage in a two-stage IPAA procedure is total proctocolectomy, or removal of all of the colon and rectum to the anal transition zone of the anal canal, and formation of the ileopouch, either an S or a J version, with protective, that is, a covering temporary loop ileostomy. The patient returns about 3 months later to have closure of the loop ileostomy. In a one-stage procedure, a total proctocolectomy is done and the ileopouch, whether J or S, is created and attached to the anal transition zone of the anal canal. The advantage is the person has no stoma. The disadvantages include increased length of initial recovery. If a complication occurs, such as an anastomotic leak, the function of the internal pouch could be compromised, requiring additional surgery and even pouch removal. Candidates for a one-stage procedure are those who have been on lower dose steroids, no immunosuppressant therapy, and have a thin body or extremely thick abdominal wall that precludes stoma formation. Most importantly, the ileopouch anal anastomosis is made without tension. Early and late complications of IPAA surgery include bowel obstruction, anastomotic dehiscence, pelvic abscess, wound infection, anastomotic stenosis requiring mechanical dilation, urinary tract infection, impotence, retrograde ejaculation, and dyspareunia. Some of these complications are significant, including recurrent pelvic sepsis, Crohn's disease of the pouch with fistula, pouch failure, and chronic recurring pouchitis. Some individuals may also develop dysplasia in the anal transition zone. Development of cancers is very rare. Significant complications are catastrophic and can lead to removal of the pouch. Dehydration is another problem that can occur when the loop ileostomy is in place or in the early postoperative time after stoma closure. It takes the pouch time to learn to accommodate this volume or the increasing capacity for absorption of liquids every 3 months, and this will occur every 3 months for the first year. This will be discussed in more detail when we talk about management of continent procedures. For those with an ileopouch, the usual number of bowel actions is 4 to 8. The individual does not experience urgency and can usually defer having a bowel action for up to an hour. People can expect to have 1 bowel action a night. Fecal incontinence is rare. When it does occur, it's usually at night when someone is in a very deep sleep and not aware of the urge to go. At these times, the leakage is usually wetness of stool rather than a large volume incontinent episode. People need to learn what and how foods affect them. People can generally eat most foods, but may have increased bowel activity from spicy foods, fruits and vegetables, particularly those in high roughage, caffeine, and carbonated drinks. This concludes our lesson on the presentation of continent procedures, fecal diversions. In the next lesson, we'll talk about management. For more information on construction of these different procedures, please refer to the references on this slide, and thank you for your attention.